Good morning. It's my pleasure to get Jerry off the hook this morning and introduce to you Dr. Kunal Sarkar, whom you probably know. Kunal's joined our faculty recently as a member of our interventional section. He comes to us from a variety of places, most notably Mount Sinai in New York and Rome, Italy. Kunal's done a good deal of work in structural heart disease, has had experience with all the toys we used before we got to him. Doctors Laurie and Naples, would you move up, please? He has very small print in his slides. So after a good deal of effort, we were able to recruit Dr. Sarkar here, and he's going to talk to us about percutaneous mitral valve replacement and give us what I think's a unique perspective on it. Kunal, let him have it.
Thank you, Dr. Kleiman. Good morning, colleagues. Today I'm going to talk about emerging spectrum of transcatheter therapies for mitral regurgitation. At the very outset, please let me say that this is not a talk to discuss which patients should get valve surgery, which patients should not, and what type of mitral valve surgery a particular patient deserves, because there are people in this institution who have been doing mitral valve surgery before I was born. So obviously I'm neither competent nor have the expertise to comment on mitral valve surgery. But what I would like to talk about is this dynamic and expanding field of treatment for mitral regurgitation. I have no financial disclosures relevant to this topic, but I'll be discussing use of unapproved devices during the course of this presentation. So since there are colleagues from all subspecialties of cardiology here, I would try to build up with a brief overview of the scope of the problem. So how common is valvular heart disease? As we know from this very famous study from Mayo Clinic, that the national prevalence of valvular heart disease in the United States is about 2.5%. And this prevalence rises in the elderly age population. And so the prevalence is more than 10% in patients who are 75 years or older. This study also had a component of a community study performed in the Olmsted County, and their results showed that the prevalence of moderate to severe MR was about 1.7%. Similar data, but from a different setting. This is the EuroHeart survey, and this is about 5,000 patients who were admitted to inpatient units for treatment of valvular heart disease. And in this setting, aortic stenosis was the most common cause per referral. However, mitral regurgitation was not far behind, and there was a significant number of patients, about 3,500 patients with native valve disease, and about 750 of them were admitted for treatment of mitral regurgitation. So we know this is a useful construct to understand the treatment, understand mitral regurgitation, primary mitral regurgitation, where the valve structure itself is abnormal, and secondary or functional mitral regurgitation is this huge subset which essentially is a problem with the ventricle, whether it is ischemic or non-ischemic, and LV dysfunction is inherently the cause of the mitral regurgitation. The valve structure is essentially normal. And even though the concepts or the treatment modalities that I'm going to talk about would be applicable to both degenerative primary and secondary MR, I would like to concentrate specifically on the unmet need in patients with heart failure who have secondary mitral regurgitation. And the first question that we have difficulty in answering is, how much of it is there? So if you review the literature, the following things come to notice. That after an MI, about 10 to 12% of patients will have moderate or severe MR. There is about 6 million adults with heart failure in the United States, 45% due to LV dysfunction, and 20% of severe secondary MR in patients with chronic heart failure is due to ischemic or non-ischemic cardiomyopathy. So a rough calculation will give you an estimate of how much chronic severe secondary MR is in the community. Now, this is another recent publication which estimates that there are about 4 million US citizens that have moderate to severe mitral regurgitation. Now, there are problems with these data, how mitral regurgitation was quantified, what was the setting, especially for heart failure patients with dynamic secondary MR, was there any standardized evaluation or not. But for a ballpark, there is a lot of unmet need that these therapies can serve. So let's build up a rationale for transcatheter percutaneous or percutaneous treatment of mitral regurgitation. The EuroHeart survey suggested that about 50% of patients who were admitted with severe mitral regurgitation were denied mitral surgery, and this was because of comorbidities, advanced age, and poor LV function. According to this publication by Back et al., 16% of patients with severe symptomatic functional MR and about half of those with degenerative MR actually underwent surgery. And this is again dependent on the expertise of the hospital concerned, but these are the data that are available. Population-based study, an often quoted study by Gami et al., only 2% of eligible patients actually get surgery. And why are these people denied surgery? Because the heart teams, the families, their primary care physicians, everybody thinks that the morbidity of mitral surgery is excessive. So what happens when these patients present to a tertiary hospital? This is Sachin Goel's study from Cleveland Clinic. These patients often have prognosis as bad as severe aortic stenosis. 1-year mortality rate is 20%, 5-year mortality rate is 50%, and they have a very high rate of recurrent admissions for heart failure. We also know that the morbidity and mortality associated with mitral valve surgery in elderly patients is very high, 17 to 35%. This is data from the Duke database. This is 1,500 patients with 3 to plus 4 functional MR, LVF over 20%, and these patients were not undergoing CABG. So for isolated valve surgery, less than 20% of patients actually got the surgical treatment. So obviously these patients are elderly, they have comorbidities, they are high surgical risk, and they keep getting admitted to hospitals with recurrent admissions for heart failure. One of the current goals of health policy is to reduce costs, and according to published literature, over $18 billion a year are spent in this country on heart failure hospitalizations. So with this background, let's review some relevant anatomy. This is a cartoon from Carpenter's manual, and this is basically an illustration of the left atrial view. The mitral valve has 2 leaflets. The posterior one has well-defined scallops, P1, P2, P3. The corresponding areas on the anterior leaflet are A1, A2, A3, and these are 2 areas at the ends where the leaflets are attached. This is the anterolateral commissure, the posterior medial commissure, identified by their own caudal attachments. Please also note that the circumflex artery and coronary sinus travel in proximity to the mitral annulus, and also that there is a close relationship between the aortomitral curtain, the non-coronary and left coronary sinus, which is important. This is an apical view of the mitral valve, and what I want to point out is the aortic leaflet, the septum is anterior, the superolateral and posteromedial papillary muscle, and the aortic mitral curtain is essentially forming the roof of the left ventricle. Now this is a close-up view of the ventricular surface of the anterior mitral leaflet, and I would like you to concentrate on these 2 ends of the fibrous continuity, which are known as the left and the right trigones. The right fibrous trigone is continuous with the membranous interventricular septum, and this is important because this is how we landmark when we do CT-based analysis of the mitral valve. And this is what the interventionalist or the operator gets to see. There is no direct exposure. 3D TEE is what is available and state of the art. This is the atrial view. This is the ventricular view. Now we know for many decades, and after this seminal work of Dr. Levine, and more recently with 3D echo, that the mitral annulus is not a planar structure. It is saddle-shaped. It has this anterior peak and the 2 naders. More recently, this is 4D echo quantification, which actually improves on the static quantification that we can achieve with 3D echo. And the same can be done with CT scanning. So just like TAVR, CT scanning is actually even more important in planning mitral valve interventions, because most importantly, we can estimate and we can study the mitral annular geometry, the landing zone characterization as it is applicable to different devices. A very important concern is, because these devices are going to be bulky, the ability to predict left ventricular outflow tract obstruction, and also it helps in predicting fluoroscopy angulation and planning of access, more importantly, transapical access. So I'll spend a minute on this. This is excellent work that has come out of British Columbia, Dr. Blanky's work. Basically, what you do is you take a long axis view of this on the CT, identify the center point of the mitral annulus and the apex, and rotate the image and mark the mitral annulus. The best point, the most visible point, is the attachment of the posterior mitral leaflet. So you follow the curve, and that way you are able to achieve a saddle-shaped contour of the mitral annulus. Now, if you're going to simulate a device, if you're going to make an area of this structure, invariably you will end up with a device that will impinge on the LVOT. So that's not correct. So the way these authors have been able to come to a more practical and a more relevant measurement is an old technique which was described in 1998. It is a mathematical concept of least squares plane method. What you do is you actually project the area of this saddle-shaped annulus, and you get a two-dimensional area with which you can actually calculate a mitral annular area, as well as something called the mitral annular trajectory. This trajectory is important because you would like to plan your access site to stay perpendicular, coaxial with this trajectory, perpendicular to the mitral annulus and coaxial to this trajectory. So let's come back. This is what the interventionist gets to see, a very dynamic structure with multiple components, not as simple as the aortic valve, which is basically a blockage, a tight calcific blockage at the end of a tube. So let's start with transcatheter techniques, and a very simple way to understand is basically we are trying to copy surgical techniques. So whether it is edge-to-edge repair or annuloplasty, what interventional techniques endeavor to do is replicate those techniques without actually cutting the chest. So if we consider that the whole mitral valvular complex has 5 components: annulus, leaflets, chordae, papillary muscle wall, and the left ventricle itself, there are multiple, more than 100 ways where you could actually repair a mitral valve. Interventionally, we have not been successful in replicating all those techniques. The one technique which is clinically available and has the most success is the edge-to-edge technique, first described by Dr. Alfieri. This is performed percutaneously with the Mitra clip. Mitra clip has been used for both degenerative and functional etiologies. It has been used in central and commissural MR, creating a double orifice or a single orifice valve. There is a significant body of clinical evidence with multiple registries, large cohort, and even a randomized trial. It is now included in the valvular heart disease guidelines, both in Europe and America. And there are ongoing randomized trials looking at the value of mitral clip therapy in patients with functional MR. So where are we in terms of development of these technologies? Edge-to-edge repair, Abbott Vascular Mitra clip. There are chordal repair technologies. NeoChord is prominent. There are ventricular remodeling technologies. There are technologies to simulate annuloplasty, enhanced leaflet coaptation, and the most crowded is the field of transcatheter mitral valve replacement. Now, these are in development, and obviously, for the sake of time, we cannot discuss each and every technology. I would take representative technologies which have had human experience and share with you what we know about it. So in Europe, there is commercial approval. For Mitra clip, it was in 2008. For NeoChord, it happened in 2013. And only annuloplasty, direct and indirect, has got approval. And no other technologies are approved yet. So let's briefly review indirect annuloplasty, the simplest approach. Basically, what you try to do is put a nitinol frame inside the coronary sinus, bend it, and try and reduce the septolateral distance in the mitral valve and try to cinch the annulus. So as I said, this is a relatively simple procedure compared to other techniques. It is performed with a 9-French catheter that is put through the right IJ approach. There is a marker catheter which is used to actually measure the diameter and length. The distal portion is put in the great cardiac vein. The proximal anchor is in the ostium of the coronary sinus. And based on the proximal and distal diameter, the device length is between 60 to 80 millimeters. There have been 3 safety and efficacy studies. This device has had a rough ride. The Methodist trial initially with 48 patients had a lot of dissections of the coronary sinus, device fractures, coronary compromise to the circumflex artery. Then the Titan trial and the Titan 2 trial has been submitted. As per a recent report, there have been over 300 commercial implants. There is an ongoing reduced FMR study which compares this therapy with optimal medical therapy. The advantages of this therapy, it is relatively simple and a quick implant procedure. The future options for the patient are preserved, whether it is CRT or other forms of transcatheter or surgical techniques. And there is a potential for synergistic use with other MR reduction therapies. There are multiple problems, and this device has had its share of criticism. There are anatomical limitations. The coronary sinus is not exactly opposed to the posterior mitral annulus. It may be at a distance, and so the therapy may itself be ineffective. Device fractures were responsible for multiple treatment failures and coronary compromise. However, when you review the data, howsoever small, it's not really a fatal therapy. There was only 1 death reported in their experience. So let's come to the more newer therapies, and this is direct annuloplasty. Direct annuloplasty is basically putting an incomplete ring in the posterior annulus, whether it is from the atrial or the ventricular side. This has been pioneered by Dr. Francesco Maizano, and I'll talk about this Valtech Cardioband system. The system essentially consists of 3 components. There is a delivery system, the actual implant itself, and then there is a tool, an over-the-wire tool, which is used to cinch this, this band after its application under TE guidance to evaluate MR reduction. So the procedure is performed transseptally, so it's a safe procedure. It achieves supraannular fixation, just like in surgery, and there is a significant reduction of annular dimensions that can be achieved, reduction up to a size 28 surgical ring. Again, this approach preserves the native anatomy, and it allows for other synergistic therapies to be used in the patient, whether they are surgical or percutaneous. So the step-by-step procedure, you make a transseptal puncture, you insert the system, deploy the implant, and then you adjust the implant. And I'd like to share this 30-second clip and actually from the University of Bonn. This is performed in the cath lab by Professor Nikinek. So this is the baseline echo. You do a transseptal puncture under TE guidance with about 5 centimeters height clearance from the mitral valve, the steerable guide catheter, and the implant within that catheter is inserted together. And you start under TE, real-time TE guidance and fluoro guidance from lateral to medial, trigone to trigone. So basically, these are stainless steel screws that are embedded within that implant, and you actually screw them onto the mitral annulus, on the posterior mitral annulus. Then you move on to the next site. And finally, you achieve a completed implant. At this time, you remove the guide catheter, the implant system, and this is the over-the-wire tool which will be used to engage the implant and actually cinch it to reduce the septal-lateral dimensions. So if you compare to baseline, this is a significant reduction in MR after cinching. Finally, the guide catheter is removed, procedure is finished. So this is the first in-man multi-center study, enrolled 48 patients, 5 centers, 1 in Italy, 4 in Germany, actually 6 centers, and 1 in Israel. All of them with functional MR, ischemic and non-ischemic, average EF of 30%. Inclusions, moderate to severe functional MR, symptomatic status, LVF greater than 25%, and the subject considered high risk for mitral valve surgery as assessed by the institutional cardiologist and surgeon. They are looking at safety and performance endpoints, overall serious adverse events and serious adverse device effects that will be followed for 24 months, and performance will be assessed at 6, 12, and 24 months in terms of reduction in MR severity and functional parameters like quality of life. So this appears to be relatively safe therapy. Only 2 deaths, 1 mortality was due to elective mitral surgery. Not many bleeding complications, only 1 episode of cardiac tamponade. And about 90% of patients were free of significant MR at 12 months, and this is core lab analysis at Baylor by Dr. Graben. Significant reductions in anteroposterior diameters, about 28%, and good functional improvement in patients at 12 months. So let's speculate for a minute that with the combination of this therapy and MitraClip, you actually could perform a full transcatheter mitral repair. The next technology that I will share with you is the AccuCinch system. This is direct annuloplasty, but not from the atrial, but ventricular side. So there have been many patients reportedly treated in Germany. However, there is no published experience with this device. So this is a modified pigtail-like catheter that engages the mitral valve annulus from the ventricular side. There is the special wire that is used to wire the subannular space, and there is a marker tunnel and then a tube which has nitinol anchors. And just like the atrial annuloplasty, you go from one side of the annulus to the end, deploying these anchors. And finally, they are cinched. So this is the modular guide tunnel, which is put inside that special catheter. The anchors are delivered through this tunnel. And finally, the cable remains, but the modular guide tunnel is removed. Now you start cinching, just like the atrial annuloplasty, and observe reduction in MR. There is a device lock at this end, and finally the cable is cut. Intuitively, this appears a little more technically challenging than the atrial annuloplasty. However, we will not know till we have some published experience with this device. So finally, we come to the most exciting and most talked about intervention, transcatheter mitral valve replacement. But before we go on, let us take a moment and actually talk about calcified or mitral annular calcification, which is a surgical challenge. And this series from Dr. Vahanian's group in Paris has used TAVI valves, the Edwards Sapien XT valve in 26 and 29 millimeter dimensions, to treat calcified mitral annulus successfully from the transseptal transvenous route. The operators were able to achieve a circular configuration of the Edwards Sapien valve, even though the mitral annulus itself is D-shaped. This was a publication in JACC, and follow-up was available till 12 months. All patients were actually free of any significant complications. There were no episodes of valve thrombosis, increasing gradients, and they were in NYHA class 1 and 2. So what is the promise of transcatheter mitral valve replacement? First, we should be able to treat a large spectrum of patients. We should be able to treat both primary and secondary MR. We should be able to eliminate MR, and it should be enduring. And finally, and most importantly, we should be able to perform it in a truly percutaneous manner without needing protracted general anesthesia or extracorporeal circulatory support. We should be able to deliver the device with simple access and closure, and we should be able to minimize the risk of major adverse cardiac or vascular events. What are some of the intuitive challenges with this technology? Because the mitral valve is not heavily calcified most of the times, it's a dilated ventricle that you're dealing with, you'll have problems with positioning and fixing the valve. Then there is problem of paravalvular leaks. These are bulky devices. There's always a question of how much valve gradient we'll generate. And because they impinge on the LVOT, there is the problem of LV outflow tract obstruction. With the new CT software, we are able to simulate by putting a disc-shaped structure on the mitral annulus and evaluate how much space there will be left in the LVOT once we do this procedure. There are risks of thrombus formation, and then the unanswered questions of durability and retrievability. So basically, in the absence of any anchoring calcium, the mitral valve devices use the structures around the annulus for anchoring. This could be the shelf of basal myocardium. This could be the mitral leaflets and chordae itself with the use of anchors, or as in tendyne heart valve, which is done transapically, a neocord is actually sutured to the cardiac apex to tether the valve. So there are about 12 or 15 valves that are described in literature. To the best of my knowledge, 5 of them have been used in human beings. All of them have some common characteristics. All of them are nitinol-based, self-expanding frames. All of them are tri-leaflet. Most of them are bovine. Tendyne valve is porcine. All of them have fabric sealing skirts, although CardiAQ is pericardial. And all of them, except CardiAQ, is delivered through transapical procedure. And that is where I'll concentrate the next few slides on the CardiAQ prosthesis, because this was the one that we used in Rome. And this was possible to be done. This was available in a transseptal variation. So this is a pretty bulky device. The delivery system is 32 French at the distal end, and it tapers down to 24 French towards the more proximal end where the controlling knob is. These are the left ventricular anchors. These are designed to grab on the chordae and the leaflets to anchor the valve. The atrial anchors are released subsequently, and they attach to the left atrial wall. So the overall experience till February 2016 is about 60 cases with 5 TMVR systems, but it has been attended with a very high 30-day mortality, about 25 to 40% officially, and up to 75% unofficially. Multiple reasons. These patients are very sick. Most of these procedures have been done transapically in very, very large ventricles. They have problems with bleeding. And because the numbers are small, the percentages do look a little inflated. However, let me share with you our work. This is the first-in-man successful transseptal procedure performed of implanting a transcatheter mitral prosthesis, and the patient lived to discharge, and then this technique was reproduced again. 4 patients have been done till now at Policlinico Tor Vergara. The first 2 patients were done transapically. Patients number 3 and 4 were performed transseptally. All obviously needed general anesthesia. The procedure time was significantly lower in the transseptal route. We had a major problem with patient number 2 because of access site bleeding, and then this patient had a very tumultuous course. He developed atrial and ventricular arrhythmias during the hospital stay, finally developed fungemia, but was discharged 25 days post-procedure. However, he expired 20 days later. The other 3 are alive and well, have been committed to follow-up. And I'm going to show you some moving images. Again, to the best of my ability, this is the first time these images are being shown in this continent. So this is baseline echo, posterior leaflet restricted. And this is, for interventionalists, this is the important trick. This procedure was not done with a single transseptal puncture. We performed 2 transseptal punctures. And I'll show you in the next one why this is important. The first transseptal puncture is, again, superior posterior. The first one is, the second transseptal puncture is 2 centimeters below the first one. And the sheath, the first one has a standard long Mullen sheath. The second one is a steerable sheath through which a snare catheter is inserted. So essentially what you have is a steerable snare. After that, a 46 millimeter reliant aortic occlusion balloon is passed to make sure that we are not under the papillary muscles. An AV rail is created with a nitinol wire, and the snare, before you send the wire up to the aorta, you go into the pulmonary artery, snare the wire, and basically what you have is a wire rail under a snare. This is a very bulky device. Please pay attention here. The mitral annulus, again, is not perpendicular, but orientated obliquely. So the snare is needed to deflect the device anteriorly into the center of the mitral annulus. The ventricular anchors are released. And then the atrial anchors. This is the final result. The transseptal puncture is closed with a large size PO4 occluder, 32 millimeters. The device is less likely to cause significant LVOT obstruction because this is most of it is supraannular. And this is 3 months post-procedure. So in conclusion, presence of MR is one of the most powerful prognostic factors, increasing mortality and healthcare expenses in heart failure patients. Non-surgical treatments of MR are emerging as a viable and effective method to improve functional status. And apart from MitraClip, more options will become available in the future. including surgery like percutaneous annuloplasty and transcatheter mitral valve replacement. Thank you very much.